Hello everyone and very good evening. I am Dr. Ajinkya Nanavre from Emcure Pharmaceuticals. I welcome everyone. Uh, Dr. Bhushan sir, your screen is there.
Oh, sorry.
Yeah. I welcome everyone to yet another enlightening session of the No Thrombosis workshop focusing on the acute ischemic stroke. The primary objective of this workshop is to present interesting cases in the management of acute ischemic stroke, and while also benefiting from the wisdom shared by our course director and to gather valuable insights from our esteemed moderators. So in our previous workshops, we had the pleasure of engaging in very unique and interesting case discussions, and we are hoping to have a very fruitful and enriching discussion today as well. And it is my honor to introduce our faculty for tonight. So let me share my screen. So I first welcome our course director for today's workshop, Dr. Subhash Kaul sir. Sir is senior consultant and stroke specialist at KIMS Foundation and Research Center, Secunderabad. He has been faculty for 27 years in Nizam Institute of Medical Sciences, Hyderabad. Sir is former professor and head of Department of Neurology and dean at NIMS. He has more than 120 publications in various national as well as international journals. Sir has been principal investigator or co-investigator of several national or international projects, including the largest single center Hyderabad Stroke Registry, which was funded by ICMR. He has won the State Teacher Award by Telangana government in 2017. Sir has been past president of AP Neuroscientist Association, Indian Stroke Association, and Indian Academy of Neurology. Welcome, sir.
Thank you.
Then I welcome our first moderator for tonight, Dr. S. Meenakshi Sundaram sir. Sir is senior consultant neurologist at Apollo Hospitals, Madurai. He is a recipient of Gold Medal and Best Outgoing Student Award for the year 2000 from the NIMHANS, Bangalore. Sir has over 20 years of experience in neurology and more than 36 publications in various national and international journals. He has presented many papers at various prestigious national and international forums and has received the Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology, Lucknow. Sir has been a principal investigator for many international trials, such as trials for refractory partial epilepsy, many stroke trials, acute stroke intervention trials, etc. He has been editor of the South Asian edition of the book Practical Neurology, and he has contributed to many other books on neurology as well. Welcome, sir. Then I welcome our second moderator for tonight, Dr. S. Rohadgi sir. Sir is professor and head of Department Neurology, Dr. D.Y. Patil Medical College, Hospital and Research Center, Pune. He is ex-consultant neurology at Armed Forces Medical Services, ex-honorable surgeon to President of India. He has published 42 papers in national and international journals. Sir has also authored a chapter in Handbook of Neurological Emergencies, and he has a recognized guide and teacher of MUHS, Delhi University and Kurukshetra University. Sir has been on UPSC panel for selections of the physicians as well. Sir is a member of IAN, NSI, ISA, and associate member of International Parkinson's and Movement Disorder Society. Sir has won multiple awards like Major General Swaroop Narayan Memorial Silver Medal Award for Pathology, DGA FMS Silver Medal, Vishisht Seva Medal, GOC in CWC Commendation twice. Welcome, sir. Welcome for tonight's session. Then I welcome our first expert speaker for today's workshop, Dr. Bhushan Joshi sir. Sir is consultant neurologist at Manipal Hospital, Kharadi, Pune. He has experience in neurology OPD, headache clinic, Parkinson's disease clinic, neurological emergencies and neurocritical care team, electrophysiology department like EEG, video EEG, Botox clinic. Sir has established a stroke unit in Columbia Hospital, Pune, which is now accredited by European Stroke Association. So, and he also has multiple publications and presentations as well. Welcome, sir.
Thank you.
Then I welcome our second expert speaker for tonight, Dr. Anjali Chowksi, ma'am. Ma'am is consultant neurologist at Shalby Hospital, Jabalpur. She has memberships of various societies like International Parkinson's and Movement Disorder Society, Movement Disorder Society of India, Functional Neurological Disorder Society, Indian Academy of Neurology, Indian Rare Movement Disorder Consortium, and ma'am has more than 20 publications in national and international journals. She has co-authored a book chapter titled Childhood Dystonia and has presented 8 abstracts at various conferences. Ma'am has also won multiple awards like the Junior Faculty Award, Travel Bursary recipient for the participation in Rare Movement Disorders course held at Nimans Convention Center in Bengaluru, travel bursary recipient for participation in the MDS AOS botulinum toxin and DBS workshop Abu Dhabi in November 2022, and a Golden AIM Award for Women's Healthcare Neurological category in 2022. Welcome, ma'am.
Thank you.
With this introduction, I would like to hand over this session to our course director, Dr. Kaul sir, for the context setting and his opening comments.
Yeah.
Dr. Kaul sir, over to you.
Yeah. Thank you very much. I think this forum by this time is known to everybody, and month after month we discuss cases of stroke in this. And my experience is that some cases are very difficult, some cases are very rare, and some cases are very simple also. Sometimes some cases are very common also. But that is what stroke is. Stroke is a mixed bag. No cases are similar. So it gives us an overall what they call real world picture of the stroke as it exists. So I welcome moderators, Dr. Meenakshi Sundaram, a stalwart, and also Dr. Rotagi, who is also equally a stalwart from armed forces. So I request you to take the discussion forward. Please invite the speakers. Yeah.
Thank you very much, sir. So can we invite the speakers to come forward? Thank you very much for the opportunity, sir.
Yeah. Dr. Bhushan sir, you can share your screen.
Is it visible? Ajinkya, it is visible?
Not yet, sir. Yeah, it's visible now.
Good evening, faculty members. Good evening, Sir Rotagi sir. Thank you for giving me this opportunity to present this case in front of you. I hope I'm definitely presenting this case to learn from your experience guidance. So this case is case of a young stroke. I label it. He is. Yeah, so the patient in this case is 32-year-old male. This is almost a year-old patient, one and a half year back. So he had no previous comorbidities, and he presented to us with the history of sudden onset slurring of speech. He was actually working from home, and he was in ongoing Zoom or some type of meeting with his office members, and while during that meeting his colleagues noticed that he started having some facial asymmetry and he's developed slurring of speech. They tried calling him, he was not able to answer the call. So the friend who was staying nearby, he went to see what happened. The patient was that time staying alone, and then they opened the door and they found he was almost unconscious on the bed. So from the onset, they started noticing his slurring of speech, within less than 30 minutes, roughly 20, they were able to shift him to hospital. On arrival, our emergency team found patient was drowsy, arousable to strong stimuli. He was able to follow some simple verbal command, of course, dysarthric. There was a tongue bite mark they noticed, and he was having left gaze preference and power left-sided complete hemiplegia. Upper and lower limb power was 0. So NIHS was almost very high, 24. NIHS was coming in the range of 24. So diagnosing it as stroke, of course, the stroke coordinated for the scan. The Columbia or Manipal Hospital stroke call. So yeah, there is this faint diffusion restriction on the right MCA territory region, and then corresponding ADC hypo signals were, of course, indicating large stroke, and we can see some cortical involvement, faint cortical involvement started happening. The scan was done within 40 minutes roughly from the onset of the symptom. So we were suspecting very large stroke, looking at the catastrophic picture of the patient, and this was all, the scan was also pointing towards that. And during the GI as a part of stroke protocol, we were able to notice this susceptibility imaging, vessel sign, SVS sign, susceptibility vessel sign. So here this large MCA was showing blooming, which is all suggestive of a possible thrombus. And in susceptibility imaging also, so compared to also showing hypoperfusion or possible thrombus in the distribution. So
can I interrupt? Can you go to the previous scan? There was some diffusion restriction on the left side also, if I'm not wrong.
So that is artifact.
Okay, fine.
That was artifact.
Okay, fine.
Yes, sir. So he was having only right middle cerebral territory restrictions, and those were evolving restrictions. Additional findings we could obtain from the scan, and though NIHS was large and patient, we decided to do a bridging thrombolysis and then take him for the thrombectomy. So we lysed patient with TNK 0.2 mg per kg dose, and after thrombolysis, patient was shifted to cath lab. Cath lab was unfortunately busy during that period, so we decided to lyse the patient initially. So after around 20-30 minutes of thrombolysis, patient was shifted to cath lab. And to our astonishment, his DSA turned out to be absolutely normal. Those vessels were opened up. Roughly normal DSA result was obtained after around 40 minutes after the thrombolysis. So next day CT was done as a protocol, and patient was not showing any bleeding in that CT scan. His power on next day only improved to for the routine evaluation of the stroke and stroking young. He was clot also. So here I think I was lucky, despite of showers, but despite of the clot being there, he was hypokinetic. And so because of this clot, we started him on next day LMWF and later shifted him on NOVAX at the time of discharge. With the consultation of a month period of time, detailed cardiac evaluation was also done, and he was also found to have coronary artery disease. He required stenting in his left main. So it was a significant out his thrombophilia profile later after 3 months of the initial event. Thrombophilia slightly obese and giving history of snoring. So sleep study was done. Sleep study showed AHI index of 17. So there was significant obstructive sleep apnea as a risk factor, and he had a significant
Hello, sir.
These
Sorry
were
to
only
interrupt.
2 risk factors shifted on antiplatelet medications, all vascular event and on yes,
Sir, you can turn off your camera. I think your network is unstable. That is why your voice is not audible clearly. You can turn off your camera and then try. Yeah.
So am I audible now?
Yes.
Yeah. I hope, you got my point. I was telling further investigation, we could find only 2 risk factors in this patient. One was his OSA. His sleep study was showing AHI index of 16, and he was found to have OSA. And smoking as a significant risk factor. His thrombophilia profile was normal. Now he's with regular follow-up. After 1 year, his MRS is 0, and he is back to his original job. He has almost no deficit now. And here I'd like to discuss a few points whether high NHS is a relative contraindication for thrombolysis. His thrombus was red thrombus, very fresh thrombus, probably coming out of his left ventricular clot. And because of that, he responded wonderfully to thrombolysis. And by the time we did DSA, the vessels were completely open. So role of susceptibility weighted imaging in characterization of stroke. So that can show us a character of an age of thrombus. A fresh thrombus is very likely to, fresh and perforating thrombus is very likely to respond well to thrombolysis. And many a time we can avoid thrombectomy by doing bridging thrombolysis. And the last question, whether I think I was lucky, whether I should have thrombolized the patient if I would have known that he is having LV clot, whether it should be, there are opinions, we thrombolize the patient with a clot, we may cause more harm by creating more showers of emboli from that clot. So this were the point where I would like to have guidance, sir. And thank you for giving me this opportunity.
Yeah, I think it's a very very good case. Before I give my comments, I would like to know from you what you said about susceptibility imaging in telling us the age of the clot. Can you tell us something more about that?
Yeah, sir, the recent paper, I was not able to get that citation, but the European Journal of Stroke Imaging, there is publication 21, sir. They have done this SWI characterization of thrombus and compared it with the DSA findings and later pathological findings in patient
Sir,
not audible at all.
Able to pick up the extent of thrombus.
Hello.
And if there are more, yeah. So am I audible, sir?
Yeah. Please repeat, sir. We couldn't hear you. We lost you in between. Please repeat.
Yeah, sorry. So, sir, they found out that SWI, if showing blooming of the blood vessel, in SWI images compared to the normal side, the affected side blood vessel, if it's having fresh thrombus, shows larger blooming compared to the normal fluid. That indicates it's more likely red and more porous fresh thrombus. So these type of patients perform well on thrombolysis alone. May not even require thrombectomy. And they could correlate it with the histopathological findings. Instead of being it a atheromatous lipid-rich clot, red clots shows more fresh red, platelet-rich clot shows more blooming. That was the essence of that paper, sir.
Yeah. Thank you. No, I think it's a great case. In fact, it is a well-known fact that if there are cardioembolic sources or cardioembolic clots or any embolic clots, except ICAD, if there are any clots from the proximal source, particularly cardioembolic source, they dissolve completely. Therefore, in most of the cardioembolic strokes, by the time they come to us and we do the MRA is normal, even though they have got a stroke. So that you have very nicely demonstrated here. And the second thing is I was observing when you were presenting that, he already had he had good collaterals also. You can see on that affected side, there were very nice blood vessels and what is also called luxury perfusion. There was very nice perfusion, which could be either just a vasodilatory phenomena, or it could be also a manifestation of the good collaterals. So this patient had, he was lucky that in time he got thrombolysis, and then he got. This is another advantage of tenecteplase. Always we know that its recanalization is better compared to other thrombolytic agents. So all in all, I think a great case, and his outcome also is good. And regarding your point that NIHS, we should not go by NIHS, that also I agree with you, because a whole lot of times NIHS may not be actually because of the dead brain. It may be just because of the dysfunctional brain. So in those cases, NIHS necessarily does not mean that the stroke is very big. NIHS may be big, but the stroke may not be big, because a lot of the things from which NIHS may be coming may be only penumbra. Penumbra also will give rise to deficit. So with that, I request the moderators to give their comments.
Thank you, sir. 2-3 things I just want to know. Before you went for thrombectomy, did you get a CT angio done?
No, sir. We only had this MRI scan, and we lysed the patient and directly shifted him to thrombectomy.
Okay. See, it is a very well managed case. Only just for the sake of discussion.
Yes, sir.
Saying, for your first question was that LV clot should be thrombolized. Of course, you have to thrombolize. Now, thing is whether this clot is a cardioembolic in origin or it is a ICAD. That is part of the intracranial atherosclerosis, where there is a plaque and on which the clot is formed. So in acute stage, we cannot say that if this is only a echo has also not been done before you are thrombolized, isn't it?
Yes, sir. Yes, sir.
So because now that things have quite changed in the case of ICAD. Because if you feel that it is a plaque in the intracranial portion of the carotids, then nowadays what the thinking is that instead of going for IV this thing, you can directly go for mechanical thrombectomy. And before you go for, I think, stent retrieval, if you are using, then better to give IV antiplatelets or oral ticagrelor, because the reocclusion is very common. So you have to differentiate whether it is a ICAD or it is a cardioembolic in source. Otherwise, the case has been very well managed. And what was the ejection fraction of this patient, echo?
Sir, first echo was showing 35-40% of EF. Later on, after angioplasty, his even ejection fraction recovered to 55%, sir.
Okay, and he has apical hypokinesia, is it?
Apical hypokinesia.
So that is the indication for anticoagulation. Only thing is, I think this was a large vessel occlusion, and the area involved, although in the diffusion it's not showing much of the MCI territory. But what are the guidelines say that if you get such a big infarct, you should delay anticoagulation by at least 7 days.
7 days. Yes, sir. We waited
So
for
because
7 days.
so there's a risk of bleeding, no?
Yes,
So
sir.
that is one thing. Thank you so much.
Yes, sir. Thank you, sir.
Sir,
Yeah, Meenakshi, please.
thank you, sir. Sir, when you have an NIHS of 24 and the infarct size is small, as you showed on the MRI, that itself told us that the perfusion defect was much more. And this is the clinical imaging mismatch which we see in the acute phases of stroke. There is a penumbra, and we don't do a penumbral imaging in all our patients. We only do a diffusion and then we go ahead and thrombolyze. So this is a very ideal case for us to thrombolyze because the size of the infarct did not correlate with the NHSs which we saw. That's point number one. The second point is the susceptibility weighted imaging. In my understanding, the hypointensity on the T2 or the GRE sequence, it is just the blood which is sitting there on the vessel wall. All I thought was that it tells us that there is an acute blood sitting there, and it means it is a proximal M1 occlusion. And there are papers which have said that, meta-analysis has said that if you have that, because it is a large vessel occlusive disease, the prognostic implication may be unfavorable. Though we should not deter us from thrombolysis, as we have seen in this case, it only tells us that there is a proximal vessel, a curvilinear hypodensity, which was seen there. That's second point. The third point is that this patient has a cardiac ischemia, as Subhash sir just taught us. Probably this patient was having pre-existing ischemic brain. There were certain episodes of ischemia, and that is the reason why he developed collaterals. He has been ongoing with ischemia for a long time, and because of which probably he escaped from this. Or in cardioembolism, sometimes patients can have large deficit which can sometimes vanish like anything called as a vanishing deficit syndrome or the shrinking deficit syndrome. Sometimes it can even happen spontaneously because the clot can get lysed. There's no fun in actually waiting. We have to thrombolyze them. And the last thing is about the coronary imaging. So about the echocardiogram before thrombolysis, we had a discussion about this. Subhaskar sir taught us about this also. When we try to over-investigate, we'll be over-inhibited. For instance, if we take it from this case, that let us say this patient really developed a complication. And next time we think that, okay, in all patients, let us do an echocardiogram also. It will only increase the time for us before we thrombolyze. So we should just treat our instinct and go ahead and thrombolyze it. In fact, I told sir earlier that we used to have a small V scan in the emergency to just look at whether there is the thrombus sitting there, which will deter us. But later on, it so happens that it really doesn't make any decision making any better for us. It is not that just because a clot is there, we'll be more hesitant. So it is just all this one say we should go ahead and thrombolyze as you have done in this case. Either remarkable. So there are two things. One, do we have the vascular imaging? Can you just show the vascular imaging once again what was done earlier from the carotids, from the down under the carotid? That's first thing. And second, do you have the repeat imaging of this patient later? Thank you.
Yeah. I don't have that repeat imaging right now with in the presentation, but the initial imaging was showing complete M1 stenosis, sir. Vascular image. Let me try and share. I'll show you, sir. Give me a minute. Probably at the end of second presentation, I can share both these images, sir. I couldn't get them in this PC from where I'm presenting, but I'll share it, sir, in 5 minutes. So
thank you. How obese was this gentleman?
Sir, he was 6 feet tall and around 110. So BMI was coming 20 to 23 around, sir. And OSA was there. So smoking was also significant. Those were the only two risk factors. I was suspecting we may get, being 32 years, some coagulation disorder. But these were the only two risk factors, sir.
And subsequent CT angio, anything was done? As sir was asking, Rohtagi sir was also asking, did we have to do any procedure subsequently for him? Do we have the vessel wall imaging subsequent to the stroke?
Yeah, we have a DSA, sir. DSA was normal. So
It did not even show any diffuse disease or collaterals
No,
or
sir.
any of those.
No, sir. No, sir.
So I have one more point to make about this is about your question of LV clot. Now,
Yes, sir.
I think Meenakshi has more experience about this. Some of his patients had some. All of us, we have had once in a while this experience that patient worsened after the thrombolysis, and the reason was a proximal clot. And this proximal clot can be in the heart, it can be in the aorta, it can be in the MCA itself. In fact, some patients who have got a MCA clot, when you give them IV thrombolysis, they can worsen because that's called migration of the clot. There's a distal migration of the clot and it migrates. But recently we had a discussion, now I don't remember where it was, between comparison between tenecteplase and alteplase, and in that they said that the advantage of tenecteplase is that it causes more distal migration, because finally clots have to get dissolved and migrate. They break up into many small portions and then they get dissolved and small, and tenecteplase is able to do it more effectively. So it is possible the experience which we used to have with alteplase may not be true with tenecteplase regarding this clot dissolution. It seems clot dissolution is much better. We want clot to dissolve. We don't want it to become fragmented into portions which can form further microemboli. So I am just thinking aloud at this time that it is possible that the tenecteplase, because of its high fibrin sensitivity, because of it is a very localized action on the clot, maybe just dissolving that clot rather than breaking it into, but this is just a hypothesis. I'm thinking about it at this time. So that is one thing. But second, another important statistical question is that should we screen all patients of for heart? Should we do echo? And so I think in statistics, what they see is that whenever they recommend any procedure or whenever they recommend any medicine, they don't look at individual patient. They look at overall. They look at 1,000 patients, 10,000 patients. How many of them it will affect the decision? If it does not affect decision in a significant way, they don't recommend it. And that is the concept of number needed to treat. If you see aspirin, the number needed to prevent one stroke must be, I think, 80 or 90 or even more than that. But still we treat all the 90 of them. Same is true about TPA also. Same is true of everything. So everybody does not get affected. It is a certain number of them. That is the whole concept of number needed to treat or even number needed to harm. So from that point of view, I don't think it is reasonable to screen every patient for doing an echo. We can be blind to that procedure because the number of people who will actually have a clot will be very, very small, and it is only going to waste our time as of today. But my other point, which I told you, that is my secret thought, that maybe tenecteplase is better, maybe it does not have that complication. That's all. But that has to be seen in future studies. Okay, go ahead. Meenakshi, you have any other point?
There were case reports of patients developing myocardial infarction after thrombolysis for stroke because of LV clots.
Yes.
But the very fact that they are actually cases.
Yeah. We can't hear you. We can't hear you, Meenakshi. Yeah.
There are case reports of myocardial infarction developing in patients who have been thrombolyzed for acute stroke because of the presence of LV clot.
But I would be interested. Yeah, true.
The very fact that there are case reports tells us that it should not take away the sheen out of our thrombolysis.
True.
We shouldn't fall for such things. We should just understand that it can happen.
But my question is, what was that thrombolytic agent?
Yeah, they were on TPAs. They were actually antiplanes.
So
all the reports were antiplanes.
Yeah. Okay.
In Green Journal also, there was a publication of 5 patients. 3 of them actually did very well. And 1 patient had recurrent cardioembolism and did not know the fate of this.
No, it is a very well-known phenomenon. It has happened with streptokinase also. For people have not got, MI is correct, worsening of stroke is correct, and distal embolization causing gangrene in the feet also has been reported. It's all because of fragmentation of the clot.
Yes.
But again, it should not defer us at all from thrombolysis. We should not, in fact, you taught us in the last time, sir, we should not do echocardiogram, which will only inhibit us. We should just keep away from this. Take it simply that patient has come with a stroke, do a CT scan, thrombolysis. I think that
Absolutely
should be
agree.
the thing for that.
Sir,
Yes.
just if you permit me,
Yes, sir.
emergency, it just takes 2 or 3 minutes to do this thing, echo in the emergency department if you have the facility, because you are doing mechanical thrombectomy. Now, the thing is that, sir, with due respect, the treatment for embolic stroke from the cardioembolic source and ICAD is slightly now different, sir. So while in embolic stroke, there is no plaque. There is no plaque. You don't have to treat that plaque which is intracranial. So now what the thing is that now what they say that if you are sure that it's not a cardioembolic stroke, there is some plaque inside, then if you have got facility for mechanical thrombectomy, you may not give IV terrectiplase and you can give antiplatelets along with this thing and do mechanical thrombectomy. That is the only thing. It's
Correct.
just question of 3 or 4 minutes putting a probe on this thing. And if you can safely execute. Secondly, sir, as you rightly said, Asians, the cardioembolic stroke is much rare than rare than the plaque. So in our population, Asian population with hypertension and diabetes and all sort of things, we expect atherosclerosis to be more common than cardioembolic. Thank you, sir.
Yeah, thanks. Thank
The
you.
point was that, sir, only one doubt, sir. The point was that we had actually a V scan, sir. Probably, sir, we had a V scan in our emergency. We had this. One of our residents was trained to actually look at only the clot. I mean, we will not be able to make out any ejection fraction. Those things are not things which is possible with a handheld V scan. But then we asked ourselves, if we have a clot, are we going to thrombolyze or not? That is a question we are going to ask. And then it becomes confusing for us. We did not change our decision. So it was only giving us a confusion.
If you have a clot in the heart, you can give safely IV terrectiplase. My contention was different. If you are not finding any cardiac source, probably it is ICAD. In that case, if you can avoid IV, although there are studies now that you can combine antiplatelets with IVT also, terrectiplase also. But to be on the safer side, it is better that you give, instead of terrectiplase, you give antiplatelets, infuse them, and go for mechanical thrombectomy. If you are considering ICAD, that is the only thing, sir.
Okay, sir. Thank you, sir.
Thank you.
So should we move? So thank you very much, Dr. Bhushan. Great case, great discussion, great learning from all of us, from you.
Thank you, sir. Thank you.
Yeah.
Thank you for guidance, sir. Thank you
Sure,
for
sir.
opportunity.
Thank you, sir. Next case, please.
Dr. Anjali, ma'am.
Presentation, sir. Yeah.
Yes, yes.
So, very good evening, all of you. Thank you, Dr. Bhushan, for presenting an interesting case, which helped us to know about the thrombolysis. So, but I will be presenting a case which is at another end of the spectrum of stroke presentation with no thrombosis, that is NO thrombosis. So, this is an interesting case with multiple twists in the tail. And so my patient was a 65-year-old gentleman who presented with weakness of left side, more in the lower limb as compared to upper limb for almost 3 days. It was acute onset, not associated with any sensory loss or facial asymmetry, no history of any bladder incontinence. He was non-alcoholic, but was a heavy smoker. He was hypertensive, but was not on any regular treatment. And he's a non-diabetic. There was no history of any similar weakness or transient attacks or any coronary artery disease. At the time of admission, his CNS examination revealed there was no carotid. Tone was increased on left side. Power in upper limb was 4/5. In lower limb, it was 2/5. Reflexes were all exaggerated. Plantars were bilaterally extensor, and sensory examination was normal. So we did the scan, and we found this large acute infarct in the right frontal parasagittal cortex and subcortical white matter with some mass effect. So because it was already 3 days, so there was no question of thrombolysis. So he was started on antiplatelets. But during hospital stay, he started having left lower limb, his movement, his power on the left lower limb improved to 4/5 within next 2 to 3 days. But he developed intermittent episodes of involuntary jerky movement on the opposite side in the upper limb. So I'll show you the video. This was recorded during his hospital stay by the nursing staff. So suddenly he started having these movements in the opposite side of the weakness, and it was involving both proximal and the distal part of his right upper limb. And it was involuntary, it was not distractible, and there was no postural variation. And these movements were lasting for 10 to 15 minutes and were occurring multiple times a day. And they were disappearing on their own. So since there was a history of stroke and just before onset of these symptoms, we did the CT angio, and what we found that there was a occlusion on the right side of ICA throughout its cervical and intracranial course, and it was there was a thinning of left ICA in its whole course. So here you can see the right ICA has almost disappeared, and left side was also thinned out. So the final diagnosis was the left hemiparesis with right frontal infarct, with right-sided limb shaking crescendo TIAs, with bilateral carotid artery disease, right-sided complete occlusion, and left-sided around 50 to 90% occlusion. So I just wanted to discuss about the symptomatic carotid artery diseases. So the common cause for the carotid territory stroke is a thromboembolism from the IC or MCA, or small vessel intracranial disease in 25% cases, cardiac embolism in 20%, and other specified rare cause in 5% cases, and 25% cases with unknown causes. And around 10 to 15% of all the strokes follow thromboembolism from a previously asymptomatic ICA stenosis. If you see the symptomatic carotid artery disease, the symptomatic refers to the patient who has a carotid artery symptom in preceding 6 months. And the symptoms, we are all aware of these symptoms, but the limb shaking TIs I want to highlight as our patient had the symptom. So most of the symptoms in the carotid artery disease are negative, but sometimes patient may have limb shaking TIA, which is characterized by involuntary limb movements caused by the hemodynamic failure in patient with severe carotid stenosis. While the crescendo TIA means multiple TIAs within a short period of time with full recovery in breathing. How to differentiate these movements from the seizure? There was no lack of consciousness, or there was no aura.
Hello.
I think we have lost, actually, hello?
Yes, sir. I will just call it.
I think everyone is off, sir. Only you and me are here.
No, I'm here.
No, sir.
Sorry, sir.
Everyone is here. I'll call Dr. Anjali, ma'am. Just a second.
Rohtaki sir is also there. Part of. Sir,
Hello.
Hello. Ma'am, your sir, I think her network is unstable. She is trying again.
Can you see my slides now?
Not yet, ma'am.
Can you see?
No, ma'am. I
Yet
think
to see, madam. It only says has started screen sharing.
I think since you have presented the case, you can just discuss it.
She is joining again, sir.
Okay.
Okay. I'll ask her to share that presentation with me, and I'll present for her.
Is it visible now?
Yes, yes.
I'm sorry for the technical glitch. As I was discussing, so there are features which help us to differentiate TIA from the seizures and the movement disorder, because sometimes it may look like a hemichorea, hemibellism like movements. So our patient doesn't have any postural variation. So there was a doubt. So we did EEG, which was normal. So I'll be discussing European Society Vascular Surgery Guideline, which was published in 2023. So if you see our case, our patient on right side had a complete carotid occlusion, and on left side he had around 50 to 69% carotid stenosis. So I would like to ask the expert's opinion how to go about this case. What should be the further management in this case?
No, first you please clarify, stroke was because of which carotid and TIA was because of which carotid?
So on right side he had carotid occlusion, on left side he had carotid stenosis. So the stroke was on the the carotid stenosis has caused infarct, while the carotid occlusion was causing TIA.
Yeah, so carotid occlusion, no, actually I think occlusion, how will it cause TIA?
Sorry, just pardon. The occlusion had caused the right side occlusion has caused the left side hemiparesis.
So that is why it's getting confusing.
Yeah,
So
yeah.
please clarify. So let us say occlusion is on the left side.
Right side, and the stenosis was on the left side.
Okay. So occlusion is on the right side, and the infarct is also on the right side.
Right side.
Is that correct?
Yes.
Yeah. And stenosis is on the left side.
And he was having right side.
TI is on the right side.
Yes.
Yeah. So I'll first tell you what is my impression about it, and later on I'll welcome my moderators also. See, this is a very this person is now depending completely on the this 50% side on his blood supply, because his right side is completely occluded. So the entire blood to the both hemispheres in the anterior circulation is coming from his left side, right? And this left side is symptomatic. It is symptomatic because it is. It's not symptomatic for an infarct, but it's symptomatic for a TIA. It's a limb shaking TIA. So TIA is as good as like a stroke as far as management is concerned, management criteria. So I think I would definitely recommend revascularization for this. But I would tell you one thing: this is a high risk revascularization, because whenever you have got a contralateral occlusion, it becomes a high risk situation. But I think this is a high risk which I would take. I would take this high risk situation. I would ask if it is an endarterectomy. I would inform them to keep the procedure time very minimum and maintain the blood pressure, because once you don't have blood circulation from the other side, the procedure is very high risk, whether it is stenting or whether it is endarterectomy. But I think I would go for stenting or endarterectomy, but it has to be done because it's a very I want to recanalize this site. Yeah. So, but I would like to hear the opinion of our moderators also, Dr. Rotagi and Dr. Meenakshi.
Yeah, thank you, sir. It's a difficult choice. Only thing, what was the serum lipids?
Pardon, sir?
Lipid profile.
Lipid profile was normal.
I mean, normal means LDL. How much was the LDL?
The exact value I don't remember, but it was within the normal limit. Although we have started him on statins, but it was not that high to.
See,
No, why Dr. Rotagi is asking that question, that the definition of normal has changed recently.
see, I'll tell you. The now recommendation is that LDL should be less than 70. Okay. We just last, sir, the call server also there. Dr. Kothari had presented a case of TIA, recurrent TIA, and he just managed the lipid levels and the patient was asymptomatic. So probably I would suggest that we have very aggressive lipid management and then we see whether the TIs are still persisting. If it is still there, then there is no choice. Then we have to go for a high risk stenting.
Meenakshi, what would you do? Leave him alone or revascularize?
Students, sir, I feel that on the right side, which is a symptomatic site for the present acute established stroke, where there is a carotid occlusion, do nothing. He is actually surviving on the collaterals or from the contralateral side. On the left side, if you believe this is a limb shaking TAA, obviously I would ask for an intervention, and the intervention would be a revascularization. Before that, I would like to know the status of the collaterals, which is a good DSA, which will tell me where are the collaterals and how good they are, sir. But I have another basic doubt to go through, sir. The involuntary movements, madam, just don't mind me asking, sir, I'm a naive person. So was there any functional component also in that patient? Are we sure this is only a TAA, madam? Because he had variable things, variable types, because it didn't give that, many times we say TAA will be mistaken for a seizure, TAA will be mistaken for a tremor. Here he was almost looking at this and doing it. And if you have the video once again, we are sure he doesn't have any conversion disorder, or am I imagining, madam? Please don't mind me asking this.
These movements were present even when he was sleeping. And the semiology was same, like both the proximal and the distal movements, and they were distractible, not distractible, as occurs in the functional movement disorder.
So just a question of doubt which crept to my mind, madam. That's why I asked you. I'm sure you would have thought of this and would have gone through all this history. Just as a observer, I was just asking, that's all, madam. If this is a carotid stenosis of significant nature, 70% you said, correct, madam, on the left side?
See, we have done
on the left side.
we have done the CT angio, so it was the exact value they have not given, but they have just mentioned as a thinning of the left ICA throughout its course.
If the carotid stenosis is 70% or more on the left side, which is producing the limb shaking TA on the right side, it would, in my opinion, be a definitive indication for us to intervene.
Yes.
Of course, after explaining the risk, saying that you can have a massive stroke on bilateral, both sides, you can have a stroke. And also there will be risk of other complications, which includes even a cholesterol embolism syndrome, because this person is likely to have a diffuse atherosclerotic disease elsewhere also. He is very much likely to have a carotid disease in addition to cardiac disease, and probably a peripheral vascular disease. Like our teacher, Dr. K. Srinivasan sir, used to teach us, for every carotid that is blocked, 2 coronaries are blocked and 3 peripheries are blocked. This guy is a big smoker, one side is completely gone. So you have a high risk procedure which includes a renal dysfunction, later cholesterol embolism, high risk of stroke, intra-procedure complication, all those things. But I don't think we have any other choice if it is a TAA like this. If the family agrees, I would like to revascularize it. This is my thought, sir.
Yeah. No, right. Yeah. I completely agree. Sometimes there are high risk, high benefit situations, like in stock market. It's a high risk, but with high benefit. But risk is also high. But if you have to get high benefit, you have to take that risk. There are low risk, low benefit situations, like giving aspirin. It's a low risk, but low benefit. This is high risk, but high benefit. This is his lifeline. If it just gets blocked, he's gone. So that's right. But I think with these high risk situations, if you have got a good interventionalist, if you're very careful, then the chances are that he should get through. For instance, now I will add one more situation to this. Suppose this patient has got a coronary artery disease and he needs a CABG. They are going to come to you, Anjali. They are going to tell you, give the clearance. So what would you tell at that time? You have to give the clearance. You have to tell them, please first open his vessel. But if it was asymptomatic, then you could have left him alone. Even if it was 90%, you would have left him alone. If it was asymptomatic, the moment it becomes symptomatic, and particularly when it is the only vessel supplying, then you have to, deal with it, knowing fully well that it's high risk. We know that it's high risk. But let me tell you one more thing, because I attend almost every meeting. Whichever meeting is happening in India, I attend it. Somebody told me, because you have no work, that's why you attend. We are busy. So I have had this discussion before also in one of the meetings, and Anand Alurkar, all of us know him. He's a very eminent neurologist turned interventionalist. It makes a difference. He said that high risk and all, Subhash, what you are telling, that is for endarterectomy. For stenting, it is not a high risk. These are Anand's words, because he does stenting. He said these contralateral occlusion and all are high risk in endarterectomy. But when it's a question of stenting, it is not a high risk. Because in endarterectomy and all, they have to do some clamping and you depend on collaterals and all. He says here it is not such a big issue. So I would offer him stenting in that case. Yeah. So nice case. I mean, you should. This is a case report. This is gold mine. This is unilateral stroke with contralateral TIA. I mean, can you beat it? It's like two aeroplanes colliding in midair. Unilateral ischemic stroke with contralateral TIA. It is fantastic. Yeah, you must. In fact, we have got a fine stroke meeting in the last week of August. Please present this case. And this extracranial disease is being discussed on Sunday itself. So you can come on Sunday. So nice case. I mean, nice case for the wonder of it. One side TIA, one side stroke. Meenakshi, you're not getting excited by this. I'm very excited. In
this case scenario, sir, one more thing, that if this patient is highly likely to have a coronary artery disease, highly likely. So if that is a case scenario, the risk of anesthesia will be very high. Sir, the point is that if you ask our interventionalist, he will say that is an ideal case for intervention. If you ask the interventional surgeon, he will say it is an ideal case for surgery. So I think we neurologists will have to take a call. In our hospital, both of them are extremely good. Fortunately, they work together and just do. We should have a team. We should sit with them and then you should make a decision. In this case, I would actually opt for an intervention rather than a risk of exposing him to anesthesia, because high anticipation these guys. This patient has got a significant carotid, coronary as well as peripheral vascular disease.
Yeah, I agree.
Smoker, sir.
I agree. I'm agreeing with you.
Thank you, sir.
So all the panelists agree that we have to intervene. Then the question arises whether we should go for stenting or endarterectomy.
Meenakshi has told you he wants to go for stenting, and we agree with him.
Sure. So, but in stenting, the long stenosis is also the left ICA is thinned out throughout its course. So that is also a risk factor for the stenting.
Yeah, Anjali, can you hear me?
Yes, sir.
I am just saying, can you first do the DSA and see exactly how much is the stenosis? Okay. And if ultimately you have to go for stenting, no doubt about it. But for this TIAs right now, we can do aggressive management of the lipids by giving rosuvastatin, high doses, and estimabib, and now those monoclonal antibodies, evolizumab and whatnot have come.
PCSK inhibitor.
That's correct, sir. So if that stops the TIA, and we can observe the patient and see how he's progressing, because it's only, it's a very difficult situation. He can become completely all right, or he may die. So, as sir has said, we do it. But before that, at least do a DSA.
Yes, sir. The The most important twist in the case is patient was not willing for any invasive procedure or
Oh.
He solved all our
we are
problems.
not able to pursue it further and he went Lama. So
So
we are
no,
trying to convince him to get at least DSA from medical college and get the stenting done as early as possible.
But if you can contact him, one of the things which Dr. Rotagi said is very correct.
Yes, sir.
Aggressive management of lipids is now the latest thing. No, we all knew lipids have to be lowered. We knew that. But the latest is that how much they have to be. Now, it is recommended to lower them to rock bottom. Meenakshi, rock bottom. 30 LDL, they are saying bring it to 30 or 20 also in cardiology circles. And they are saying 90 or 70 is too high. And everybody should do it, not only stroke patients. So this is the latest thing, and which Dr. Rotagi said, what Sudhir showed, we don't know. It was just one case. We don't know. He presented a case of recurrent strokes, which was not controlled by anything. Finally, he was given that monoclonal antibodies against lipids. And he said the TIA stopped. You know, that is one thing that led to a lot of discussion, but there was theoretical discussion whether it would have stabilized plaque acutely. But leaving that aside, this LDL is a real villain. LDL has to be kept rock bottom as of the current thought. That 100, 120 is too high. It has to go definitely below 70 and 60, 50, 40, like that. Yeah.
So I'll call the patient and we'll do the same.
Yeah.
Thanks for your advice, sir. So as of now, I have started him on dual antiplatelet, and the plan is to shift to clopidogrel after 21 days of dual antiplatelet and convince him to get the stenting done as early as possible.
One of the things which I would recommend is that rather than clopidogrel, put him on tecagalor. Because clopidogrel, what happens is that about 30 to 40% of people are having resistance to clopidogrel. It's now well established. Even in India also, in some centers, but all over the world. So this is I would not say it in every patient, but here the stakes are very high. You know, we don't want to take a chance of him to have a clopidogrel resistance. So give him tecagalor 90 milligram twice a day, plus aspirin 75 milligram, at least for 1 month with high resistance lipids, high strength lipids, anti-lipid lowering agent. Because we want to do our best to prevent a recurrence. And by 1 month, he may be able to decide what to do.
Madam, there has been pooled analysis comparing cardiac endarterectomy versus endovascular procedure. In fact, they always fight with each other. Very rarely we have people who don't fight, which is the case in our hospital. I'm proud to say this, madam. We have excellent team and we don't have this controversies. We don't have that risk problem at all. But what is generally said is that the surgeon's mortality periprocedural risk should be actually assessed. We should have our own data. That is, it should be less than 6%. That is one of the requirements in subjecting to endarterectomy. Between the two, as of now, we say that though endovascular, sir was talking about Anand Alurkar sir, they all do excellent work. But still, if we take on a head-to-head trial, because cardiac endarterectomy is a senior, it still supposedly holds an edge, especially in people who are older, 70 years and plus, where you have this high incidence of a stroke, is where it still has an edge. In a younger, because number one, the peri-procedural risk, if you look at the endarterectomy versus endovascular procedure, peri-procedural risk, the risk of stroke and those complications is lesser with endarterectomy than procedure, whereas the risk of myocardial infarction and those things are actually lesser with endovascular procedures. Myocardial infarction and the cranial nerve injury, these things are lesser. But stroke risk per se is higher with endovascular procedures. So probably as of now, a small edge is there, number one, because endarterectomy is a senior pro, and this one is there, but still endovascular procedures will actually rule the roost. That is the future. It is going to stay. This is what I feel, madam. In this case, I think it is a call based on TSA, which has to see all the way from here, because in a transfemoral approach, which most endovascular procedures are done, we should know whether we can access that site. There should not be a significant carotid disease or hiatic disease which prevents us from accessing from a transfemoral route. Because in which is, if that is the case, then people should be familiar about a transcarotid access for us to do an endovascular. So all those comforts have to be taken because this is a real smoker with systemic risk as well. These are my thoughts here.
Thank you. Thank you. Thank you. Thank you. There's one more disclaimer in that, Meenakshi, which Anjali has shown,
Yes, sir.
that she showed us the guidelines, and the guidelines have left it to us. He says it depends upon the particular hospital, whatever the clinicians decide there. But there is one more thing within inverted commas. Considering everything what you said, I completely agree with you that in this each case to case basis. But there's one more variable in this, that in your hospital, in my hospital or anybody's hospital, who has a better expertise? Your hospital is an exception, Meenakshi. They are both equally competent. Then that is okay. When they are both equally competent, then we can decide. But sometimes in some hospitals, what happens is that clearly the endovascular person may be more competent than the stenting, or vice versa. In some hospitals, stenting person may be much more competent than the endarterectomy. There, obviously, the choice is easy then. Then you don't have so much. But when you have got both are equally competent, then obviously we can take a decision. Yeah.
Not only competent, they should be nice enough to talk with each other. So
Yeah.
then it becomes easier.
They should be doing 10 surgeries per year and the mortality should be less than 6%. So I don't know who is going to get this data.
No, they will never give it. They will never give it.
Not give it.
They will never. In PGI Chandigarh, where I have done my DM, there used to be mortality meetings. But surgeons were exempted from mortality meetings. It was only for physicians.
I also attended. Sir.
Yeah. Okay, sir. Anything else, if any comment before we give to organizers?
Thank you, sir. Thank you very
Both
much.
cases.
Thank you, sir, for your
Excellent cases. Excellent presentations by both speakers.
Thank you, sir.
And excellent moderation. Everything was excellent. Thank you, sir.
Thank you, sir. Good night.
Good night,
Yes,
sir.
sir.
Good night.
Yeah, sir. As usual, sir, this workshop was very remarkable with an impressive online view count of more than 132. And I'm sure our audience must have derived immense benefits from this. I would like to thank everyone for sparing some time from your busy schedules, especially on this weekend meeting. And I would like to thank and congratulate Dr. Bhushan Joshi sir, Dr. Anjali ma'am for their interesting case presentations. Special thanks to Dr. Kaul sir, Dr. Meenakshi Sundaram sir, Dr. Rodgi sir for their expert comments and valuable practical insights. Working under your guidance in future programs would be an absolute privilege, sir. And with these closing remarks, we bring this session to an end. Once again, thank you, everyone. I wish you a very delightful weekend ahead. Good night.
Thank you.
Good night.
Thank you.
Thank you, sir.
Thank you, sir.
Good night, sir.
Thank you, sir. Good night.
Thank you, Rodagi, sir. Thank you, sir. Thank you, Kaul,
Thank you,
sir.
sir.
Recording stopped.